Okay, muscle tissue is one of the basic tissue in the human body. There are general characteristics for all types of the muscle, because we have 3 types of muscle. I will be talking about each one separately. The cells are called muscle fiber. In the muscle tissue, rarely we use the terminology of cell, not in cell, I mean muscle fiber. They have ability to contract, and embryonically they are mesodermal in origin. Except for the smooth muscle of iris, which is called pupillary muscle, which dilate and constrict the diameter of the pupil, is ectodermal in origin. Hamu muscle, mesodermal, except for the smooth muscle of the iris. It contains contractile protein. How the muscles, regardless of which type it belongs to, it contains contractile proteins which are called actin and myosin. The muscle tissues are arranged in groups. يعني within each particular muscle, the muscle fibers are grouped and forming fascicles or bundles covered by connective tissue or these connective tissue layers separating the fascicles from each other, and they act together to produce the mechanical force when they contract. 3 types of muscles are skeletal. In certain textbook or reference, they are called striated muscle. And it's found mainly in the association with bone, because that's why it's called skeletal muscle, because it moves the skeleton. It contributes about 40% of the body weight. Imagine the weight or the percentage of the skeletal muscle found in the healthy individual. The cardiac muscle, which is exclusively is found in the heart, and smooth muscle found in the hollow organs. It means the organs which has cavities, like, for example, stomach, small, large intestine, uterus, urinary bladder, and so on, blood vessels. There are special terminologies belongs to the muscle tissues. For example, the muscle cells, we can call it muscle fiber or myocyte. The sarcomere, you know, each cell is covered by a thin layer of membrane called cell membrane. In case of muscle tissue, we call it sarcomere. Sarcoplasm is the cytoplasm of the muscle fiber. Then the smooth endoplasmic reticulum inside the cytoplasm of the muscle is called sarcoplasmic reticulum. Sarcomere is the contractile unit of myofilament. I will be focusing on it thoroughly because it's very important, and it is the contractile unit which function in the muscle. Sarcosome, the sarcosome is specialized long mitochondria found in skeletal and cardiac muscle. يعني mitochondria غير نوعية تعبدية ودريش كولير. لا شيء زيادة لا skeletal ولا cardiac. Skeletal muscles, they are voluntary. It means it's under your control. You can contract and relax your muscles. It is striated. The cytoplasm contains transverse striation. Under the microscope, this striation is due to transverse dark and light bands, which are because of the actin and myosin filaments. They are attached to the skeleton through tendon and moves the skeleton. Skeletal muscle fibers, the cells here, or the muscle fibers, are elongated and arranged in parallel way from its origin to its insertion. يعني muscle, for example, originally كلها insertion اللي Why? Because they produce together. They produce the same function. The connective tissue, which covers this skeletal muscle fibers or the whole skeletal muscle, is important to carry the blood vessels, the lymphatics, and the nerve. And the connective tissues arranged as follows. epimysium. This is the muscle. The muscle يعني as a whole يعني muscle كناري كتايبتي يقول من biceps, triceps, gastrocnemius هاد الشيء. It's covered by thick layer of connective tissue, thick layer called epimysium. Then, as I said, the skeletal muscle fibers forming these groups or bundles called fascicle, muscle fascicle, it's covered by a thinner layer of connective tissue called perimysium. Then, what's found within each fascicle? Muscle fibers. Muscle skeleton. These are covered by a very thin layer called endomysium. So epi, peri, and endomysium. And as you see here, we have blood vessels which are running through this connective tissue. It is used as a path to transmit the blood vessel and to supply the all parts of the muscle. Here the muscle is attached to the bone by tendon, as you see. The muscle fiber is cylindrical, and they are multinucleated. As it was seen here, this is the elongated muscle fiber. Esta é a muscle fiber here. Striation here. أو خدنا striation بيودي كلا light and dark band بيقالوا. And the nuclei are peripherally located, multinucleated. The multinucleation is referred to what? To fusion of the many myocytes during the embryogenesis, during the process of histogenesis. لكاتي كمصل دروس أبيض كوت مع الميزوديرماية مجموعة mesodermal cells differentiate to form, for example, skeletal muscle. فنجاشز دانا يك أجرين أبي بيك muscle, skeletal muscle. لبرو أبي بفايبر دو دريجة. And the nuclei are located just beneath the sarcomere, peripherally located. The cell membrane of the two adjacent cell myocytes embryonically starts to dissolve or disappear. لبرو يكشي في cytoplasm here, nuclei كان يشي لسروا يعني لجير ولا جير sarcomere دانكرا. The cytoplasm, KPLN sarcoplasm, shows alternative dark and light band. Dark band كتيا بيوت A band, light بيوت I band. هادو كيشانسين contractile protein كأكتينو مايوسين. In the middle of the dark A band, there's a pale region called H zone. These H zones, they're line, awana. Each one has its own physiological significance and function. استمن بس هنا كنت تقول إشي مني بس أنا dark band pale area here, as it's shown here. This is the dark band, light band, and this is the dark band. You see a pale area at the middle of the A band. It's called H band, H zone. And H zone by itself is divided by a line called M line. Kawata awal America AHM. Kabanda kaya pale area kat H khadakinawi M. While the I band or the light band is bisected by a Z line. The space between two Z lines is forming a sarcomere, which is a contractile functional unit of the muscle, especially in skeletal muscle and cardiac muscle, because no sarcomere is found in smooth muscle. This is a line that separates one sarcomere from another. With one, Khoshitsiya Z line bisected here, I band, light band. A line is central line of the sarcomere where myosin filaments are anchored. كواتهري كان إشي إم لاين شيء أم لاين كبر إيش لاين كهاتوا لويا ما سين كان أنكرين يعني شون عليه كيوي مساواة join together. The A band include overlapping myosin and actin filament. لا سيرك ال A band توزق لمyosin filamentيش هاتو بس actin filamenta يعني overlap كا. So this is the muscle you see, and this is one fascicle. What's found within the fascicle? Many of these muscle fiber, and each muscle fiber in the cytoplasm of each muscle fiber there is elongated thin fibrils. يعني بتشك راوة تمام. Fiber كبتشكي double fibril. باش يعني filament, which are formed from what? From these two types of contractile protein, actin and myosin. باشا أما actin و myosin. These actin and myosin give this striation to the skeletal muscle. Myofibril, as I said, the cytoplasm full of parallel myofibrils. They are of two types. Thick myosin, كأيبان البودروزاكا, thin actin, أيبان البودروزاكا. And how the contraction takes place. However, this is the physiology, and you will be studying it in the musculoskeletal system, the physiology of the muscles. The thick and thin filament slide upon each other during contraction and relaxation, and the process will be completed. Now, this image is showing the sarcomere. We are focusing on sarcomere because very important structure in the skeletal muscle. As you see here, we have two Z lines bisecting area chia aibanda. Awina ras chia aibanda. You see in the relaxed state here, there is a bit overlapping between the actin and myosin. When the muscle contracts, there will be shortening of the sarcomere because there will be more approximation of the actin filament, and which will approach each other beneath the myosin filament. In fully contracted, the skeletal muscle, each skeletal muscle, هل muscle work in the skeleton? The muscle fibers are not of the same type. يعني لهر muscle ده هم fiber كان عيني نوعية. We have three types. The two main types are red and white skeletal muscle fibers. The red fibers, the characteristic, you should focus on the characteristic or properties of each type. Red fiber, it has small diameter, varicule. They are fatigue resistant, contain more myoglobin and mitochondria. Basha, that's why it's called red. طبعا حتى myoglobin is a protein which is red in color, and it binds the oxygen, and you know the muscle, especially skeletal and the cardiac muscle needs oxygen more than the other types of tissue. So it needs a protein to carry this oxygen. As you know, in the blood we have hemoglobin, which is also a protein which binds to 4 molecules of oxygen. I'm a physiology. So, returning back to the red fiber, you should know small diameter, they are fatigue resistant, rich in myoglobin, mitochondria, and they are capable of sustained long period contraction. And the contraction is slow and steady. يعني بهيواشي contraction كا ورده يعني زيادة كا لسرفورة. This skeletal muscle fiber, the red one, is need the oxidative forces using the aerobic pathway. They are predominant in the postural muscle in the limb, or in the upper limb. يعني للشان وملو أنا postural limb, postural muscle كان red muscle fiber. يعني this image shows this is the same muscle containing both type of fibers, red and white. So the red fibers, because they are slow twitch muscles, slowly contracts, and they are using oxygen. That's why they are called aerobic. And the oxygen is maintained through ATP. Usually they are used for the marathon runner. While in those they have fast twitch muscle type, which is the other type, or wide fibers. They have large diameter, containing less myoglobin and mitochondria. That's why it looks like a bit paler than the first one. It cannot sustain contraction for a long period, and they are called fast fiber. Fast fiber, يعني contract for short period. They predominate in the extraocular muscle. Extraocular muscle. Ocular muscle يعني مصلاني تشاوجوا لنا extraocular. The intermediate one, the structurally and functionally they are intermediate between the both red and white, and it is considered as a subclass of white type. لبعض الشوينات شيء كدوا نوع على type 1 و type 2. Type 2 A و B. A كوايت type هي كشرة يعني intermediate again. Because it is a little bit looks like white fiber more than the red. They are found dispersed among the red and white fiber. أمانة شوينة كتابت يعني أنا شغلابة ولا بيجي red و white أكمل. Slow twitch. red fiber أكانة. سيدك أما صلاب هنا ما دام slow twitches زيادة red muscle fiber هي. أما يعني fast twitch كه يعني زوج contraction كه هنا white كيزور كه. Transverse tubule or T-tubule and sarcoplasmic reticulum. They are very important for the physiology of contraction of the skeletal muscle. What is related to our subject is its histological structure or feature. Lechipia T-tubule, like sarcoplasmic reticulum. T-tubule is our invagination of the plasma membrane, يعني sarcolemma. لعملي دامنا برسمك جامبو ساركومير لما أجت الناوة بوكو تيوبيك دروس أكا أميانا أما ساركوليما هاتوت الناوة it is blind-ended tube يعني أم سيكراوني أخوارو ناوي باشا it contains ion channels which is important for the process of the contraction. Then on both sides of the T-tubule there is an expanded end of the sarcoplasmic reticulum. As you see, sarcoplasmic reticulum is a network-like structure which covers each myofibril. The expanded portion of the sarcoplasmic reticulum called terminal cisterna or cisterni. Basha, together. Each T-tubule with these two terminal cisternae forming a structure called triad, which is specifically found in skeletal muscle. Rasha? And the location of the T-tubule or the triad is at the junction between the actin A and I band. You see here? This is I band and this is A band. The triad is located at the junction between I and A band. They conduct electrical impulses for the release of calcium from adjacent terminal cisternae. What's found in these terminal cisternae, calcium ion is stored here. When the contraction starts, the electrical signaling which coming from the motor nerve. The motor nerve here supply muscle كدوة شيكا electrical signaling yet بناو T-tubule affects on the terminal cisternae to release the calcium, which initiates the process of contraction. أما شر فسيولوجي أما ليت ناقص مو بس بزانا structure ترايد لتشي بيكاتو لتشويش هاي لمصل فايبر كان لا مصل فيبر لكان لم دوشتو تيجي برا بيكاتو لجنكشن اوف أو مهمة junction between I and A band. Innervation of skeletal muscle. Usually the main innervation of the skeletal muscle is the motor because its function is movement. وأنا أبي موتور نيوروني هذا يعني موتور نيرفي هذا. So each single axon is the extension, a single extension from the neuron or the nerve cells. Unfortunately, this year we cannot teach you the nervous tissue, which is very important. We hope to teach it in the nervous tissue module in the third stage, in the S6, I think. أودو صالنا يخوين كزور مهميشة. يعني أنا استندوش أنا nervous tissue أنا كانوا كزور مهميشة. Expanded portion is designed for storage of the calcium. A motor neuron and all the muscle fibers in their best together is called motor unit. كليت ببرسي motor unit شيا علي همو motor neuron كلا قبل همو أو مصلك innervation كا بيوتين motor unit. Motor and the plate. Motor and the plate. It means the junction between the end of the motor neuron with the each single muscle fibers. Motor and the plate has another name, myoneural junction. It means the junction between the muscle and the nerve. It is a specialized synapses of terminal button of a motor neuron with the sarcolemma. يعني أكزونا كهي نهاية كان بيتوا أن نسيب sarcolemma. لبيا interaction ولا بين nerve carries electrical stimuli and the sarcolemma. And لبيا جاء شكل tubular تواو أبيها ترى شيء ترايد ورسالة. In order to contract each skeletal muscle fiber normally requires innervation by motor. يعني هل أواني نيرف بيت الناس سكليتال مصل كهموي بقولي أبي كل مصل فايبرين innervation يخو بجابو بيت باشا قريبا أجر فاسكلة innervation يبقى فاسكلة يقدر توشي paralysis بيت بجاب يعني بتنيا هم مصل كنا لبرو each muscle fiber should be supplied by its own motor neuron. This is the muscle fiber. As you see, it contains light and dark band, and this is the axon of the motor neuron. Its end is expanded, it is joined with the sarcolemma. Here, synaptic vesicle, مش physiology, not detailed. Say that the main nerve start to branch, giving branch separately each single muscle fiber. يعني هل muscle fiber أبيه innervation يكون بديها هو بفرعتي وهاتوا. This area كلاهين تجربي درختوش تجر. This is the motor and the plate. The sign of the junction between the motor nerve and the muscle fiber. This is the histology. أنا جمع كسكوبة أعوائي. أنا أفزنا كيا. أنا مش motor and the plate. أنا مش muscle fiber. What is neuromuscular bundle? Neuromuscular spindle. Spindle. It is stretch or circle. How the muscle stretch through the stimulus which is carried and acts on the neuromuscular spindle. Also, we can call it muscle spindle. يعني أو muscle spindle. All human skeletal muscle contain encapsulated يعني surrounded by capsule. Proprioceptor known as a muscle spindle. Proprioceptor يعني it feels the locations يعني شيء aware And this structure consists of a connective tissue capsule surrounding a fluid-filled space. Histologically, muscle spindle here. Capsule here, the connective tissue, space here, here. So, fluid-filled space surrounded by a capsule containing a few long, thick muscle fiber. لنا structural muscle fiber here, skeletal muscle, they are modified type of muscle, skeletal muscle fiber, which are short and thin. They are called intrafusal. Why intrafusal? Because they are found within the muscle spindle or intrafusal epithelium. The other skeletal muscle fiber, which are outside the muscle spindle, are called extrafusal. يعني the rest skeletal muscle fibers are called extrafusal fiber. Is there any confusion? يعني همو skeletal muscle fiber كان يتر هاد extrafusal بلان أماني لنا أو structural epithelium intrafusal. Yes. This is fusiform أو fusilar لو هاتو fusiform تشيلية درشكولية surrounded by external capsule connective tissue containing these small, short, modified type of skeletal muscle fiber called intrafusal fiber. And this space contains fluid. And as you see here, the nerve starts to enter to this structure and branch surrounding each of these intrafusal muscle fibers. The other striated or skeletal muscle fiber outside this fusiform structure or muscle spindle are extrafusal fibers. How about the nerve, sensory nerve supply for muscle health? Motor innervation here, and sensation has this, the sensory nerve, you know, the nerve in the body are of two types, sensory and motor. The sensory nerves also enter the muscle spindle and they detect changes in the length of extrafusal muscle. And this gives information to the spinal cord. يعني muscle spindle area يشكي contraction نيا يشكي feeling a sensation. Because the nerve that enter the muscle spindle is of sensory type. The muscle spindle participate in the nervous control of the body posture and the coordinate action of the opposing muscles. يعني شلون أساني رق دانيشتو رق وستالي حاجة دانا وشوية نكلارة وانا through these proprioceptor muscle spindles. The second type of muscle is cardiac. It's also striated but involuntary. It's not under your control. It contracts and relaxes spontaneously. Usually, the sarcoplasm contains single nucleus, but some of the cells are containing 1 to 2 oval, prominent and central nucleus. The sarcoplasm contains many mitochondria. You know, the heart is very vital, important organ. It needs large or to act to perform this powerful, important function. It needs oxygen and energy, which is obtained through the large number of mitochondria and glycogen granules, which are found in the sarcoplasm. Also, it contains lipofuscin pigment, which is a pigment specifically found within the nerve and the nerve cell, neuron, and the cardiac muscle fibers. The mitochondria lie in chain between the myofilament. Mitochondria can with elongated mitochondria. Shima field terminology. Sarcosome, yes, sarcosome. Here they are forming or arranged in a chain. لبنوا heart يشكل زور كرسا ونيا energy زورة mitochondria أو نزورة همويان series يعني بسكروا يعني linear structure يعني بسكروا. The cardiac muscle fibers are branched. So they are branching here and join through this dark joining between the two adjacent cardiac muscle fiber is called intercalated disc. Intercalated disc is very important in the physiology of the heart, which is increasing or participating in the rapid spread of the cardiac stimuli, يعني or contraction current. The cardiac muscle has diet, triadinia. باشا السكليتال أو ثمان ترايدا. diet كتشي هي tubule هي لقليك terminal system. Yes. So this is important. Let's see what's formed from the intercalated disc. It appears a dark transverse line between the two adjacent cardiac muscle fibers. It is formed from junctional complexes. And EM يعني electron microscopy. This is not seen the detail of the intercalated disc, not seen by light microscopy. أتواني أما ببيني رسمي light microscopy. But detail كي نتشي بيكاتوا أم سيشتا needs electron microscopy. Sorry. Electron microscope. It's composed of these three components. Labarican joint, لو أنا فرعي بالامتحان. Composed of zonular adherence. Zonular adherence or fascia adherence. أوش أبيت. Macular adherence. ناوي كي هي desmoson. لقل gap junction. باشا. بس أماني بس سوق مسراوي زاني دي تلاتة زاني مشكلة مية باشا. These three components together forming the intercalated disc. باشا. Now in this image you see this is one cardiac muscle. This is the intercalated disc in between them. أما تسيو ميتوكوندريا على السبرينجا. أنا شيء ندرس كدوة أبينن. أما سترايشنا. كاوي كالكو كاكاريكا كاوي توخكو كاكاريكا سين اكتينو مايسين يعني ساركوميرا كان تا استاباج من بيدن زربان معه باشا. So these are the three components of the intercalated disc. Lastly, we have smooth muscle, which is involuntary, non-striated, striationitiania, fusiform in shape with single large round nucleus at the center. The sarcoplasm contains abundant mitochondria with some rough endoplasmic reticulum and large Golgi complex or ganglion. The cytoplasm is full of actin and myosin. However, there are no sarcomeres in the smooth muscle fibers, but doesn't mean that there are no actin and myosin. How they contract if there is no actin and myosin. But the actin and myosin, they are dispersed within the sarcoplasm and they are anchored or attached to the sarcolemma in positions or in the places called focal densities. يعني instead of arranging themselves in the regular way like sarcomere in the cardiac and skeletal muscle fiber, بقشوا بلامية بلام فور أوانا نساوم بساركوليما كcontraction كان مصلك أجولين. There are three types of smooth muscle. They have the same morphology or histology تقريبا هميان, but because of the biochemical and functional difference, they are classified into these three types. Visceral, which are found in the viscera, يعني أوش تعني hollow organs in the thoracic cavity, abdominal cavity, and pelvic organs. Because there is poor nerve supply, it has no such powerful nerve supply like which is found in the skeletal and cardiac muscle fiber. So the contraction starts from one cell or group of cells, then it will be transmitted to another one. يعني مجموعة ياكل. That's why they are producing a worm-like movement. ماشي؟ in the peristalsis. And how this stimuli or this contractile stimuli is transmitting from one cell to another through the gap junction. Gap junction is type of junction found between two or between the cells. يعني gap يعني كوني ورد the gap junction. The contraction in the smooth muscle is slow and in waves. The second type is vascular. From its name, it means the smooth muscle which is found in the wall of the blood vessels. They have intermediate filaments containing ventine and desmin. These are two types of contractile filaments, in addition to actin and myosin. It has the same functional feature as visceral smooth muscle. Lastly, we have smooth muscle of iris, which is embryonically is derived from a different origin, which is ectoderm. And rich nerve supply. That's why the eye is very sensitive, and it tells it traumatic, it's very painful. This is the structure of the smooth muscle. In this image, we have longitudinal section. So the cells are fusiform, broad at the middle and tapered at both ends, with centrally located nucleus. And here you see the actin and myosin, how they are anchored or attached to the sarcolemma. يعني وقت نتوكل يعني دروس كتبوا حمية بينكم بس راونو إيوالي خانة كشوا. And thank you. What does remodeling mean and what are the types of remodeling? In addition to cover the alteration of the neuromuscular transmission, there are abnormalities maybe in the muscle related to the transmission. Also, we will talk about muscle dystrophy. So these are the main three topics that I'm going to trying to cover in this lecture. Although the details are upon you definitely, if you need more details, you can go and search for more details. Regarding the first topic, which is the remodeling of the muscles, in general, what is remodeling? Remodeling is a continuous process in which there is loss of the proteins with replacement of these proteins. So the extracellular component, the proteins inside the skeletal muscle fibers, are continuously lost and replaced. This is normal. But what happens in pathology is either the loss is more than the replacement, or the replacement is more than the loss. So we got a problem. If the loss is more than the replacement, what do you expect to happen? Atrophy. Yes, very good. Atrophy will result if the loss is more than the replacement. Atrophy, or the full term is hypertrophy, you can say just atrophy. Atrophy means that there's loss of the content of the cell. On the other hand, if the replacement or the formation of these proteins is more than the loss, then on the opposite side we got what is called hypertrophy. Very good. So we got hypertrophy of the skeletal muscles. So this is a very simple concept. Okay, now let's talk about atrophy or hypertrophy. It is the decrease in the size of the cell through loss of the intracellular components and organelles. So there will be a reduction in the content of the sarcoplasm, the glycogen content, the myosin filament, the actin filament, the organelles, all the ultrastructural organelles, mitochondria will be decreased. So the net result is a reduction in the size of the cell. As a result, when we have the whole cells or the majority of the cells lose their size, what happens? What do you expect to happen to the muscle? What do you expect if there is loss or decrease in the size of the, yes? The size of the muscle, what happened to it? The size of the muscle, as a result, decrease. So simply there is
mean that the muscles are atrophied. There is reduction in the size of the muscles of the right one. So this is atrophy. As a result of the reduction of the size, there will be what else? A reduction in the power. So the muscle is not working normal as the other side or the other skeletal muscles of the body. This one will be more weak. Okay. So why is this happening to the muscle fiber? What's happening? What is the pathogenesis behind? There is usually a reduction in the requirement to live for this muscle. So either there is a reduction in the blood supply or oxygen supply, nutrition, hormonal stimulation, and so on. We have list of causes. So the cells will not die, it will adapt. The cell will adapt the new condition by living in these limited conditions. They are living with the limited requirements. With the reduced blood supply, with the reduced oxygen supply, so they reduce their size, to reduce their requirements. This is what's happened. This is the meaning of adaptation. That the cell wants to live, and it will continue to live, but in these situations, in new situations. So this is the adaptation. Now what are the causes behind? There are many causes, in fact. General causes of atrophy in the body, not only in the skeletal muscles, anywhere in the body, even glands, will atrophy because of the same list of causes. What are these causes? Again, reduction in the blood supply on the top, decrease in nutrition, decrease hormonal stimulation. If there is reduction in the hormone stimulation for an organ, this organ is going to respond by reduction of its size. For example, in the uterus. After labor, because of the reduction of the hormones, the uterus have to shrink to return its normal size. This is physiological. Right? Physiological reduction in the size. So it is not always a pathological problem. It happens in our body. Or could be pathological. Decrease motility or mobility. This we call it disuse atrophy. Disuse means when you do not use this gland, the gland is going to atrophy. Or when you are not using this muscle or that limb or maybe crippled or something, so that limb will atrophy. We call it disuse atrophy. Yeah, also we have loss of the nerve supply by trauma, by cutting, by surgery, by anything. So when you have a trauma or loss of the nerve supply, again, the organ will atrophy. Aging by itself is a physiological process in which there is atrophy of the most tissues. Okay? Infections sometimes are associated with atrophy, like H. pylori bacteria in the stomach. It causes atrophic gastritis. It causes active gastritis. If it is persistent for long period of time, it will change into atrophic gastritis. It means reduction in the gland of the muscles. And we have also genetic causes. We call it muscular dystrophy, and I will talk about this specifically in this lecture. So these are the general causes of atrophy anywhere in the body and in different organs, and they can affect skeletal muscles definitely. Okay. Now let's see the histology. I think from the first hour you have a good idea about the histology of the skeletal muscle. So how to describe which one is normal, the left or the right?
The left.
Which is the normal muscle here? The left or the right?
The left.
Yeah? According to your hands. Left is normal. What is the abnormality in the right? If I ask you to compare and tell me the difference between the left and the right. Yes? Yes, very good. There is a reduction in the size or the diameter of the single or individual muscle fiber. This is, by the way, cross section or longitudinal section. Is this a cross section or longitudinal section of skeletal muscle fiber? Both of them. Yeah? Cross section. sections. These are cross sections of skeletal muscle fibers. In cross sections, we don't see striations, by the way. We don't say this is striated, dark light zone. We don't see it. It's just a cross section. So here, let's say that this one is a single fiber, this one is a single cell, this one is a single cell, so on, okay? Each one of them is a single cell. And each of these cells have how many nuclei? Is there single or multiple nuclei in skeletal muscles? Multiple nuclei, very good. So we can see there are multiple nuclei in the skeletal muscle fiber. So this is a single cell with multiple nuclei and apparently, and this is the sarcoplasm. Now this is normal. What we see, almost all the cells are of the same diameter, let's say the same diameter, the same size, and also in between there is very little amount of connective tissue in between, which is the endomysium. Between the individual skeletal muscle fiber and the other, there is very thin or little amount of connective tissue in between. So this is normal. But here, this is from a patient with atrophy. What do you see here? As your colleague said, she said that there is a reduction in the size. You can see there is variation in the size. Some are still not so much affected. Others are highly affected. Small, very small in size, some of the fibers. Others are larger in size, so there is atrophy. In addition, what is the second difference? Yes? Yes, very good. Who else? What do you see? What is the difference? Yeah? Very good. In the endomysium, there is separation. There is separation of these skeletal muscle fibers. So there is atrophy. They will be replaced by more fibrous tissue in between. So you can see separation of skeletal muscle fibers, not like this one. They are very compact, but here they are separated because of the reduction of skeletal muscle fibers, so this is atrophy. Okay. Now, let's talk about some of the examples of or causes of atrophy. We said that aging by itself is a cause of atrophy. And this begins after 30 years of age. Okay, after 30 years, you have to practice some kind of sport to keep your muscle size. Otherwise, physiologically, it will be reduced with aging. After 30 years, there will be a reduction in the size and the bulk of the muscles. This is, let's say, a young person, and this is an old person. And 50% of the muscle will be lost by the age of 80. So you see that usually old age people, they have atrophied muscles, even if they are obese. But when you palpate them, you see that there is usually they are just fat. Underneath their muscle is very weak and very small in size and so on. So even if the person is obese, old age obese person, but their muscles are highly atrophied. Disuse atrophy. I said disuse means that you will not use the muscle. If you do not use the muscle. So let's say a person with let's say immobilization, maybe because of crippling or unconscious patient or any cause. This patient or this person will undergo or the muscles supplied by you. The immobilized muscles will be affected, even if it is localized. Let's say a patient with a fracture. He will not use a limb, just one limb, or one upper or lower limb or whatever. So this part will be immobilized for a long period of time, so the response will be reduction in the size of the muscle. Okay. So in old age, in addition to the aging process, the type of the lifestyle, which is the bed rest, the sedentary lifestyle, the passive movements, all of these will lead to reduction in the size of their muscles and wasting of their muscles. So aging is a cause, disuse is a cause, denervation is another cause. What we said, there is cut of the nerve supply, maybe the nerve itself or maybe the motor neurons in the brain are affected. So in all conditions, the muscle supply by that nerve or these neurons will undergo atrophy. But after healing, let's say there is the trauma is healed, or after surgery there is a cut, and then there is healing, and then you use your muscle. This again will be built up again, and there will be good recovery after months. You may ask how the nerve recovered. Is it a terminal cell? How can the nerve recover? Do you have an idea? Yes?
Doesn't.
Can nerves recover when there's cut of the nerves by surgery, for example? Do you think the nerves can recover? Nerves all over the body. Yes, they can recover. Once the neuron, the body of the cell is intact, the axons can regenerate. And nerves are just the axons. So they can elongate and reach the target organ, and the organ will function again. This is in the second year question. Okay, no problem. Let's go now to the opposite, which is hypertrophy. Hypertrophy, as we said, is an increase in the size of the individual muscle fiber as a result of increased intracellular content. So if the whole cells or the majority of the cells of a muscle increase, the net effect is increase in the size of the muscle itself. You can notice that there is increase in the size of the muscle itself, and definitely the power. Keep silent and pay attention to the lecture. So hypertrophy, as we said, the proteins in the cells will increase. The extracellular components are going to increase. So the net effect is increase in the size of the whole muscle, increase in the activity of the muscle again, increase in the enzyme activity, the glycolysis, the glycogen content, the mitochondria, everything will increase in hypertrophy. And the power of this muscle is going to increase. Now the causes behind increase, mainly for skeletal muscle, the causes are increase in the workload or the demand. Just like in heavy weightlifters, when they practice such exercise, their muscle will adapt the new condition, they want to live with this increased demand. So they have to adapt the new condition by increasing their intracellular components. So the proteins in the cell, which are the actin protein, the myosin filament, will increase, and the power of the muscle increase. Or increase in the hormonal stimulation, again, not only specific for skeletal, but even for smooth muscles, for glands, as we said, when there is increase in the smooth muscle, let's say the pregnancy again is the best example because there is hypertrophy, then atrophy. In pregnancy there is hypertrophy, and then after labor there is atrophy, which both are physiological, not pathological. Both of them are physiological. Up to now, is it clear? This is the easy part, right? Just increase in size because of increased demand, decrease size because of this decreased demand. That's simple. Adjustment of the muscle length also is a type of adaptation. The muscle also can change its length according to the requirement. If there is stretching, continuous stretching for a long period of time, the muscle will elongate. Let's say a patient has a fracture or something, and then, or crippled by maybe a crippled type of crippled patient, and then they correct this deformity of the limb. And then they, let's say it was, the bone was not straightforward, it was oblique or something, tilted, and then they straightened it. So the muscles around this bone has to elongate to adapt the new condition. And this will occur gradual process by adding more sarcomeres. And the opposite is also true. If a normal muscle, you put it in a plaster for a long period of time without any immobilization, without stretching, you know that mobilization is stretching, continuous stretching for the muscles. If there is no stretching, the muscles will adapt the new condition and they decrease their size. But this is continuous process. It is, let's say, a reversible process. It depends on the activity. So this is another type of adaptation. In addition to other types we are going to study next year, which are metaplasia, which are, let's say, even dysplasia and other types, mainly metaplasia, and hyperplasia is another type of adaptation. Now the other abnormality to be covered in this lecture is neuromuscular transmission. I think you have an idea about this in the first hour. What is this diagram stand for, or this figure? Yes? Yes, very good, the synapse. This is the synapse. Synapse is the junction between blank and the blank. Yes? What is a synapse?
The connection between the nerve and the muscle fiber.
Yes, it is a connection, the site of connection between blank and the blank. Neuron and muscle, very good. The site of connection between the nerve and the muscle. So this is the end of the axon. I will stand here, I don't know what I'm going to see. Anyway, this is the end of the axon. It is dilated and in front of a button-like area. And this is the muscle, here the skeletal muscle fiber. The junction between the axon and the muscle is called the end plate. And how this works? Yes, here from this end, from the end of the nerve, this is the end of the nerve, there is a release of the acetylcholine. The acetylcholine will be released from the nerve, and it will cross the synapse, and it will go to the muscle, okay? And in the muscle, it causes release or the entry of sodium, release of calcium, and then contraction of the muscle. It will join to its receptor, as shown here. Again, just like concentrate on the previous image. On this one, I will magnify this part in the purple rectangle. Okay, it will be this part. So what happened here under magnification? This is the nerve or the axon, the end of the axon, and this is the muscle, as I said, the pinkish one, and the yellowish is the axon. And these particles are the acetylcholine particles. They join the receptors. What are the receptors? What are the receptors? On the muscle. So the receptors are located on the muscle, opposite this side, this area. So we call this area is the synapse. And when they bind to the receptor, the receptor will open. It is called nicotinic receptor. It will open and allowing influx of sodium, release of calcium, and the net result is contraction of the muscle. This is normal physiological contraction. This is a normal condition. Now all our movements are related to the same action, how the muscle contracts in this process. So this continuous process. Now, there is an enzyme which is called acetylcholine dysphase enzyme. So this enzyme is going to destruct what? The acetylcholine, right? So when we say acetylcholine dysphase, so this enzyme is working on what? On acetylcholine, causing, let's say, breakdown of this acetylcholine. So the contraction stops. That's it. Easy, right? So the enzyme will cause the breakdown of the acetylcholine and the contraction will stop. It will not persist. This is normal. So now we'll talk about some abnormalities. Our lecture is about abnormalities, not normal conditions. Now there is abnormality in this area, in this zone, which is the synapse. In some diseases, one of them is the myasthenia gravis. This is very famous disease. You will face it a lot in your life. In hospital, definitely you are going to see several patients of the myasthenia gravis abnormality. What is this abnormality? What is the pathogenesis of this abnormality? It is in the synapse itself. This is an autoimmune disease. Autoimmune. You know what is autoimmune? Yes, it is immunity against our body. So there's antibodies against these receptors. So they block the receptors. Once the receptors are blocked by these antibodies, the acetylcholine cannot reach the receptor. So there is no contraction. So there will be weakness of the muscles. That's it. easy, right? Simply there is antibodies against the receptor. And the receptor will be blocked by these antibodies. So there is no place to join the acetylcholine, that's it. So there is no contraction. The muscles will be relaxed. This process or this disease is a gradual disease. It starts at different ages. Usually starts maybe at, you can discover a patient in childhood, you may discover a patient in younger age or in middle age and so on. Usually females more than males, but it can affect both. Definitely. Okay. So this is the synapse of a normal and of a patient. Which one is the synapse of the normal and which one is the synapse of the patient? Yes? Right one is? Right one is? Okay. And left? Left. Okay. So left is normal. Right is the patient. And is left and right. Okay. What are the differences? Give me the number differences between these two figures. Enumerate the differences in these. Raise your hands. Raise your hands. What are the differences between normal and patient with myasthenia gravis in the synapse? This is the synaptic region which is the pathogenesis of this disease. Others, yes? Yes. Yes, very good. The receptors are much more in the normal. So in the disease, there is reduction in the receptors. That's it. It's very good. There is reduction in the number of the receptors for patients with myasthenia gravis because the other one is normal. So there is no, we don't say there is increase here. We say there is decrease here because this is normal. So there is a reduction in the number of the receptors for a patient with myasthenia. What is another abnormality in patient with myasthenia? Yes, very good. There is flattening. Flattening of this area, of the end plate. Here there is close, and the close increase the area. In any organ, in our body, in the intestine, there are villi. Why? To increase the absorptive area. In normal, we have these folds in this muscle, in the skeletal muscle, to increase the area, increase the number of the receptors. But in the patient with myasthenia gravis, there is a flattening of the muscle zone with the reduction of the number of the receptors. What else? The most important thing is the antibodies. Excellent, the antibodies. You are seeing something new, not present here. The antibodies. Here, this is the main problem. These antibodies cause either destruction of these receptors and the flattening, or just they occupy it. And when they occupy it, there's no place for these particles. What are these particles? The acetylcholine. So it will find no place to attach. And the end result, there is no contraction. This muscle will be relaxed and lax and so on. And there is an enzyme which is not present in the figures. What is this enzyme which is normally present in our body? In the synapses? Acetylcholine. This is very good. This enzyme, its function is to disrupt these particles to stop their function. It has a role here to be mentioned. I will mention the role. Okay, so I will mention the majority of these differences, very good, that we have these differences with the widening of the synapse. So the end result is weakness of the muscles, but the process is gradual. Keep in mind that this process is gradual. The patient notices a continuous process of weakness of the face, when you talk to the patient, you hear there is a slurring of speech because the muscles of the tongue are weak. And even when they swallow, they have difficulty in swallowing. The face expression, as I showed you the figure, I will show you the figure. This face is also typical for myasthenia. There is a drooping of the angle of the mouth. There is a dropping of the eyelid. There is the expression which is passive, or sometimes when they talk, they will show their teeth because they cannot open unless they do it with difficulty. So they show their teeth when they open the mouth. All smiling expression and so on. So all of these are related to the weakness of the muscles of the face, in addition to all the muscles. will be gradually weakened. Keep silent, you. I can see you, okay? Okay, so there are weakness of the majority of the muscles. The face, then the upper limb, the lower limb, and the most dangerous thing in the whole story, which muscles? Respiratory muscles. When the condition progresses and there is weakness of the respiratory muscles, definitely the patient cannot cough. So they reach a stage in which they may die because of swallowing, or because they have difficulty in swallowing and chewing. They cannot control the tongue mobility, but this is a gradual. Keep in mind, this is very slow process and gradual. Okay. Now what about the treatment of myasthenia gravis? Returning to the enzyme. They will inhibit the enzyme. This is what is available. Okay. This is what is available, is to inhibit the enzyme. And what is the function of the enzyme? Break down the acetylcholine. So you are keeping acetylcholine in place more. You allow the acetylcholine to be present for a longer period instead of being distracted quickly. So this allows more time for contraction to occur. This is one method of treatment. The other method of treatment is by giving drugs, and the other drug is usually prednisolone. You know it? You know prednisolone, or corticosteroid groups of drugs. These are, they decrease immunity. They are lowering the body immunity. And why they are lowering the body immunity? Excellent. Because this disease, the pathogenesis of this disease is, what is it? What is the pathogenesis? What is the abnormality? It is also, what is present in the sinus? Antibodies. The antibodies. So you are now giving this drug, excellent, to minimize the production of the antibodies, which are the main problem in this disease. So you give corticosteroids. Okay?
Tabii mikrofonun işgal.
So, but in addition, there is no definite cure, but this is the available modalities. The other condition is botulism. Now, what is botulism? It is also a problem in the sinus. In the sinus, again. What is the sinus? It is the motor and the tape. Motor and the tape, the junction between the nerve and the muscle. Okay. Here in this botulism, it is a toxic material, toxins. This toxin is present from bacteria, and the bacteria has spores. The spores live in water, in soil, okay? And this bacteria will persist. Because they are in form of spores, they persist the environmental conditions, so they live for a long period of time. If you eat contaminated food from soil, contaminated by soil, or by untreated water, dirty water, these may be contaminated with these spores, so unfortunately the person will get poisoning and toxicity. They will release the botulism toxin. And this toxin is very rapid acting. It goes, again, it will work in this synaptic region and will lead to block of this synaptic region, preventing the release of which is the dynamic molecule, the acetylcholine. So it prevents the release of the acetylcholine from the synapse, so there is no muscle contraction. The muscles will be relaxed. Is this clear? So again, because it is very easy, the toxin is reaching the blood. When it reaches the blood, it has very quick action. Not like in myasthenia, it is a gradual process, taking years and months and so on. No, this is a very rapid process. Within hours, the patient may die within hours. Or maybe just for the second day or so on. Depending on the dose of the toxin they ingest. Light is not working. Where is the power cord? Everything is okay.
belli gidiyor.
Okay, so again, what happened in botulism, that is because of bacteria, Clostridium botulinum, and we said that there is spores, and these spores persist the environmental conditions, and they persist in water and soil. So if anyone eats something contaminated with the spores will release the toxin, and the toxin reach the blood and spread quickly, causing paralysis of the muscles by inhibiting the release of what? Inhibiting the release of what? Inhibiting the release of what? Acetylcholine. So simply there will be a release, inhibition of the release of acetylcholine, and as a result there will be paralysis of the muscles. And again, the most dangerous muscles to be affected are respiratory muscles. Whether it's paralysis of the respiratory muscles, definitely the patient will need ventilator and interference, target interference. So what is here, just to show you what is Botox. Botox is the famous, what we call it, the face mask product, which is used by most dermatologists, aesthetic medicine, and all of these branches, which is aesthetic. It is to remove the wrinkles of the face, of the forehead. It is from this toxin. It is botulism toxin. That's it. It is botulism toxin. It is the toxin of the Clostridium botulinum. That's it. And the function of it, when they give it in low doses, very low doses, under medical supervision, and this is by certain manufacturers, they produce in very low doses, injecting this type of toxin. They paralyze the muscles underneath. And this is temporary. And this will be released, and it will be removed by the body gradually. So it causes a relaxation of the muscles underneath the injected area, and giving impression that the face is relaxed, or what to say, there is no wrinkles, there is no movements, and so on. So it is the same concept, but here it is given in the low doses, and it is the same toxin by the same bacteria prepared in labs. Returning to our subject, now what is the treatment of patient with the toxicity? Now you get a patient in the hospital, in the emergency, who is suspected to be now has a poison or toxin, which is botulism. First you admit the patient to the emergency part, and you put the patient on ventilator. Because we said that the most important thing is to save the respiratory muscles. And why this is not working? And also, sometimes there is available in some hospitals an antidote or antitoxin. If it is available, the patient is lucky, he is immediately the antidote, you block the action of the botulism, and the patient will survive hopefully with the subsequent days. The toxin will be released from the body. Is this clear? How botulism works? How the toxin works? It is very easy, just to block the release of acetylcholine, so there is paralysis of the muscles. That's it. Clear? Now we talk about muscle dystrophy. Clear up here? Muscle dystrophy, it is a group of inherited diseases. Again, they are progressive, slowly growing diseases, and gradually happen. Their problem, what is the problem now? Is it in the muscle? Is it in the synapse? Is it in the nerve? Here the problem in the muscle itself. The synapse is normal. The nerve supplying is normal. The motor, the end, the axon, everything is normal. The synapse is okay. But the problem in the muscle itself. What is the problem in this disease? There is, let's say, disappearance or absence or reduction in a protein which is called dystrophy. Dystrophy protein. This protein is absent from the membrane of the skeletal muscle fibers. This protein will be either in a reduced amount or absent. This protein is present in the cell membrane or the sarcoplasm or the sarcomere of the skeletal muscles and cardiac muscles. So both skeletal and cardiac will be affected, unfortunately, not only skeletals. The function of this protein is stabilization of the membrane, of the skeletal muscle membrane, or skeletal muscle fiber membrane. If the membrane is weak, if the membrane, there is no dystrophy, so there will be weakness of the membrane. And as a result, the content of the cell will go outside. So if the content of the cell go outside, what happens? The cells are going to die with time. They are going to degenerate with time. So this is a cause of cell degeneration and death. One of the important components in the cell is this enzyme, CPK, which is creatine phosphokinase. When there is increase in the blood of this enzyme, this indicates that goes with the diagnosis, it goes with the diagnosis of muscle dystrophy. This enzyme is measured in this disease because it indicates there is a problem in the membrane. This enzyme is intracellular. If you find high level of this enzyme in the blood, so there is a problem, there is muscle degeneration. Either skeletal muscle degeneration or cardiac muscle degeneration. And even in MI, this enzyme is raised. What is MI? Myocardial infarction. So even in MI, CPK is raised. CPK, creatine phosphokinase, is raised because there is cardiac muscle degeneration. Okay. There are many types. This is just for you to know that there is a wide spectrum of this abnormality, which is muscle dystrophy, and their things are sometimes related to the distribution of the affected muscles. If we say, for example, E distal, this is E, so the distal muscles are affected more than the central or the face. Facial, maybe facial, more the face is affected, the weakness affecting the muscle of the face. And as I said, the condition is slowly progressive and increases with time. The degeneration is increasing with time. The commonest one, which we face in practical life, is the first one, the Duchenne. Keep in mind, Duchenne muscle dystrophy. This is what you are going to see in your life. Either Duchenne or Becker. They are put together. Either Duchenne or Becker type of muscle dystrophy, this is what we see, in which there is either reduction or complete absence of what? Yes? Of what? Of acetylcholine, of dystrophy, of acetylcholine dysphase. What do you choose? What do you think? No idea? Why? What is missing in this disease? Is it acetylcholine, acetylcholine dysphase, or dystrophin protein? Dystrophin protein. So, in the whole spectrum, there is a problem with this protein. But what we face is Duchenne or Becker, what we see. When they send us a muscle biopsy, sometimes looking for muscle dystrophy, they are looking for Duchenne or Becker. But they need a special type of stain and immunofluorescent microscope to see the abnormality. First, let's say an advanced case of muscle dystrophy. Not all patients in this stage, but this is advanced. We said there is muscle degeneration and contractures because of the degenerated muscles were replaced by fibrosis, and then the muscle contracts and causes this deformities of the body. The most common type, as we said, it is the Duchenne muscle type dystrophy. In Duchenne type muscle dystrophy, there is a non-pathogenic gene which is DMD, Duchenne muscle dystrophy gene. DMD means Duchenne muscle dystrophy gene, which is present on chromosome X and all of this genetic abnormality. There will be progressive muscle weakness, and this starts usually in childhood after, let's say, 5 years, and they will progress gradually until the muscles will be all, majority of them, degenerated, and the most dangerous thing is the involvement of the respiratory and cardiac in this disease, because we said that dystrophy is present in the cardiac muscle as well. That occurred in the third decade. What is the third decade? Give me example of the third decade. How much, for example? How many years? Give me an age. 30? What is third decade? Give me an age. Say this is third decade. Give me another example. Give me example of a patient in the third decade. How many years? Give me anything in your mind. Patient in the third decade. Yes? 35. Do you accept?
25. 25.
They refuse. This group said no, this is wrong.
25.
Give me a patient, yes?
25.
25. Do you accept? Patient 25 in the third decade or what? Third decade, what is the first decade? First decade, 0 to 10. So second decade, 11 to 20. Third decade, 20 to 30. So 25, 23, 21, etc. Not 34. No. When we say third decade and 20s, patient in their 20s, the patient usually die in their 20s, in the third decade. Now this is very important. This is diagnostic. This image is diagnostic. Again, what is the normal, what is the abnormal? Quickly. Which one is normal, above or below? Above is normal. Why? This is not connected tissue. First, I will explain what is this. This is a stain for dystrophy. A stain for the dystrophy. And the dystrophy is stained by immunofluorescence. What is the dystrophy again? What is it? What is the dystrophy? Exact location. Where? In the cell membrane. In the cell membrane. So again, this is a cross section. So it should be present in the cell membrane. In normal muscle, skeletal or cardiac. So what is the normal one? Above or below? What do you think, last group? Above? Very good. So the above is normal, is written. Why it is normal? Why? Yes, answer why it is normal. Why the upper one is normal? It is a stain for dystrophy. What does this mean? These lines. What is this and this and this? No, not connective tissue. This stain is specific for dystrophy. We are seeing just dystrophy. So it means it's present. That's it. It means that the dystrophy is present in the membrane, so this is normal. If we take from any one of you, we got this result, which is normal. We got the lining, which is dystrophy, the protein lining the muscle fibers. We are just seeing the dystrophy. This stain for the dystrophy only. And this is from the patient. What do you see here? Below. What is the abnormality below? Yes, there is no stain. So what does this mean? There is absence of the protein. In which condition we have absence of the protein? In dystrophy. So this is in muscle dystrophy, which is here. in the exam. This is diagnostic. You have to explain why it is absent, or what is the stain here that is absent, because there is no dystrophy. So this is patient with Duchenne muscle dystrophy. Now clinically, this patient, we said it is progressive. It starts at early childhood, let's say 5 years or around, maybe earlier, maybe a little bit later. Anyway, there is waddling gait. What is waddling gait? It is walking like a duck because of the weakness of the muscles of the hip girdle. So the muscles are not supporting the pelvis very well. So the patient will move with time, just at the beginning, as waddling gait with a lumbar lordosis. This is lumbar lordosis, means protrusion of the abdomen, again because of weakness of the muscles of the back. So that is lordosis. What else? With time there is inability to jump or hop and so on, and even to walk. With time there is weakness, progressive weakness. And this sign is called the Gummer sign. When the child is sitting trying to raise, they will do it in steps, in different steps. First, they kneel on the floor, limbs to support their body. Then they try to extend their lower limbs, and then they push their knees to straighten their bodies. And this is all in early stages. In later stages, they are completely normal. It is genetic disease, so there is no treatment, unfortunately. But we give corticosteroid. And hopefully the gene therapy can produce the dystrophin proteins and support the patient.